You are listening to the Wrap on Aging podcast. I'm your host, Rob Entz with the Utah Commission on Aging. And today we are talking about advanced care planning, specifically advanced directives and POLST agreements. My guests are elder law attorney Troy Wilson and healthcare provider Dr. Cami Collette. So now let's talk about the specifics of a Utah POLST agreement. What is it? Who needs it? When do they need it? And how do you do it? First, Troy, it's a medical order. Please review with us again the legal effect of a medical order.
You're right, Rob. Because it's an order from a physician, medical responders can follow that. If somebody shows up, if somebody has a stroke or they're down at the park and 911 is dialed, EMS comes and the paramedics show up. Their job is to save a life, to resuscitate and to get him to the hospital. With a POLST form, that can be overridden. They can ignore. So when people want to do not resuscitate, the only way to do that in Utah is with a POLST form. It doesn't matter if they have a note in their wallet that says don't resuscitate. It has to be a properly executed POLST form because those are signed by a physician. Otherwise, the first responders are going to follow their protocol and they're going to provide emergency resuscitation and get you to the hospital, at which point then a doctor can take over and make certain decisions.
So Troy, I'd like to hear from you and then hear from Cami on this as well. People get so confused about a DNR, do not resuscitate. Can a DNR stand alone, or is it more commonly now part of a POLST document?
In Utah, it's part of a POLST document. I've not seen a standalone DNR, but maybe that's because we have access to the POLST form. And typically, a POLST form is going to be executed when somebody's either terminal or they've got a real serious illness. It typically wouldn't be your 30-year-old mountain biker that's going to execute a POLST form or a DNR, because if they have an accident or something else that might commonly happen, chances are they want to be resuscitated and they want to be treated.
Cami, any thoughts on that?
When I usually meet the patient after they've already come through the emergency room, they're in the hospital, and I'm meeting them for the first time. And we're wanting to find out how sick they are, do they understand their illness, and also to make sure that they have capacity, because if I don't feel the patient has capacity to make decisions, I immediately need to find the healthcare proxy and find out and talk with that person. But if I'm able to speak with the person directly, I always ask them, this is a standard question that we ask, when people come into the hospital: if your heart should stop and you are not breathing and you've actually died, what would you want me to do in that situation? And that is when they often would say, if they're older, they say, well, if I'm already dead, then do not do anything. And that essentially is DNR. DNR, sometimes people think, well, I have it tattooed on my chest. Well, that's not a legal way to do it. So I think that we have to understand that every time you come in the hospital, you will be asked that, but you may be asked it in a different way. Some physicians, they may ask, if your heart should stop, do you want us to restart it? Now that totally implies we can. In reality, the survivability of a 65-year-old over 65 in the hospital whose heart has stopped and they are not breathing and they have died, 83% die. So that's a real statistic that most people don't understand, and yet we try to allow people to make it. The 17% that do live, half of those are dead within the next year. So CPR is not always the best intervention in 65-year-old people who are sick in the hospital because they are seriously ill. So I always like to make sure if they understand what I can do CPR or not. I want to know what there is. If they have a POLST form, I'll review it. I say, oh, I see you have a POLST form. And this is what it said. If you ended up needing a feeding tube, you wouldn't want one. So I would review that. So that is what I do. And if they don't have one, I offer if they would like one, if they are seriously ill and might die. I think it's important for them to have that decision-making before they lose capacity.
So you've talked about the timing of the execution of a document. Someone who's seriously ill, someone who might be, imminently faced with death. And oftentimes these are executed when people are admitted to a long-term care facility. You talked about the importance of having family members involved in the conversation. Talk a little bit more about how you do that.
I actually like to have a family conference. I work out of St. Mark's Hospital, and we have the luxury of pastoral care. We have a wonderful pastoral care group that trains people to be pastoral care. And they have these chaplains. They come and they sit and we talk with the family. We have a social worker, a case manager, and then I'll invite as many family members that really want to attend. However, we cannot have chaos or toxic talk. So we will make sure that we have the family members that are important that will be able to be there and contribute. But if it deteriorates into something that could be on Family Feud, I need to diffuse the situation and say, let's reconvene. We'll take some breaks and then we'll reconvene and discuss this. We don't always get to discuss it with the patient because sometimes the patient is too sick or incapacitated. So I do like family meetings, and I do like including everybody to have a say and maybe to tell a story about their family member. Then that gives that family member life, even though they're at the end of their life.
So Dr. Collette, on the agreement that we're showing, the POLST agreement on the screen right now, you can see that it's broken down into several components. And there's an area aside from the personal information that deals with the DNR decision. And then there's a section on what kind of medical intervention, a section on nutrition, and then patient preferences. Could you talk a little bit about how you walk people through those things and what kinds of things they need to be thinking about?
Well, many people don't understand what it means to be on dialysis, what it means to be getting antibiotics. So I do try to tell them what this type of medical intervention is. If they need a feeding tube, they can have a feeding tube in their nose or in their stomach. So I go through more details. I think that it's important to review the comfort care. Comfort care does not mean giving up. It does not mean that we're not going to do anything. It is a very viable alternative. And sometimes when we choose comfort care, we can get the patient out of the hospital and they can actually live longer on hospice than having them in the hospital with all the interventions that we doctors do and literally, unfortunately, torture some people to death because we keep doing things to patients. And sometimes it's time to allow them the dignity of comfort care.
So Troy, there are again consequences of not having this kind of a document in terms of treatments or not having an agent or a proxy in place. Talk a little bit about what you've seen and that can happen when someone doesn't have a POLST order.
Well, I think the main thing is that you might get treatment that you don't want, because under the law, doctors, I think, are required to treat unless there's clear evidence that the patient doesn't want treatment. That's why Cammie mentioned when the patient first comes in, she has that conversation with them. If you were diligent with your advanced care planning and you didn't have a POLST form executed because you weren't seriously ill at the time, but you assigned or appointed a healthcare agent with your advance directive, then that agent can go ahead and execute a POLST form for you at that time. If you didn't do that, under Utah law, there's a pecking order of priority and who can execute those on your behalf. It starts with your spouse, then your children, then your parents, and so forth. It goes down a list, and you have a slide on that. But those are called healthcare surrogates, and those are people who can step in place if you've not appointed somebody of your choosing to decide for you. But by having somebody execute a POLST form, they can avoid the type of interventions that you don't want to have done to you if you can't make that decision.
So to be clear, you could designate a healthcare agent, but if you do not, then you say it is statute in the state of Utah that this pecking order would determine who has the authority to sign in your behalf.
To execute a POLST form,
Execute a POLST.
or make medical decisions for you as well.
So Cami, we talked in our section on advanced directives about the timing of review. Are they similar for a POLST agreement? Walk through those 6 Ds again.
Yes, they are very similar for the POLST agreement. If the death of their proxy, the person who I'm supposed to talk to, I have to find out who the new proxy is. If there's a divorce, that still applies. Then I think when a POLST form is often used more is when we have a new diagnosis, a decline in health. I do not wait every decade to review a POLST, because if I'm filling out a POLST with somebody, usually every year. So that is important. And I do want to know what their wishes are. So the Ds still exist and are very important to review. And then I have to make sure that they still want the care, and if they want to change the care. Sometimes they may want to change the care from limited care to the comfort care, because they're now ready to transition to hospice care, which is a real wonderful alternative of care. So the Ds become very important to review with each of the patients. And usually I'm doing that with family members when the patient's incapacitated.
So every now and then we are confronted in society by an emergency, circumstances that no one could foresee. Could be a pandemic, could be an earthquake. Those are circumstances where it makes it more difficult to execute documents in the normal expected way. Can we talk a little bit about the process that can be adopted for ensuring that these documents can be executed in times of emergency?
There are some facilities that are allowing electronic signatures if you are able to actually get an electronic signature. But what's more common, because most patients and family members do not have that capability of electronic, is we will use a two-witness on the phone. I may be talking to the relative in New York, and I may be asking them, this is your mother's condition. These are the things we're thinking of doing. And we can have another person on the phone, have them verbally give consent. We will print the name instead of sign it. And then we would document that we had two people. Usually they're a doctor, a nurse, or two nurses, but we have people that document, not just one, that this is the person that is giving permission for either a POLST form to be filled out or a procedure to be done.
And so what we have shown as a slide on the screen of an emergency process that the state of Utah is using. And it talks about how these things need to be documented to make it effective. In addition to that, you had some good counsel, Dr. Collette, about how important it is for people to review their POLST agreement when they are in a clinical or hospital setting, like reviewing the charts and making sure that something exists, that it's complete. Talk a little bit about the things you would have people do in a chart review.
Chart review is actually when other people, medical records, or someone goes through and says, is this form completed accurately? Did we hit all the boxes? If you're doing it electronically, sometimes you can't sign the form until all the boxes are correctly checked. On a paper form, you literally have to go through and read through it and make sure that this is what has been mentioned, we reviewed it, and no empty boxes are left without something in it. Unfortunately, I've seen forms filled out and filed electronically in a chart, but all the diagnoses are not there, and then the goals of care of the patient aren't maybe filled out. And those are very vital aspects of the POLST form, is what is their diagnosis and what is the goal of care for that patient.
So that's exactly the wrong time to figure out when you're missing something, is when you actually need it to work for you, correct?
Right. We wanted to be able to be up to date, and it's nice to review it beforehand and review it at an annual wellness visit. But in the emergency, it's nice to have ready access to it and not have it in a safe deposit box.
So Cami, final thoughts about helping people understand the importance of these documents and preparing for end-of-life conversations.
I think everyone over 18 should have an advance directive. that should be considered emergency preparedness, not end of life type issues. If we think of it as emergency preparedness, like we think of earthquake preparedness, everyone over 18 should have that. There are several states and several places that do it a very good job. And then there's others, 66% of the US population does not have an advance directive. So we have a lot of work to do. If someone is going off on a college or a mission of some kind, boy, they should really figure out an advance directive in case they get injured on this adventure of their young life. So, and then as you get older, I think you need to revisit it with your family members around the kitchen table, not the ICU bed.
Thank you. Troy, your final thoughts.
I would reinforce exactly what Cammie said and add to that, if they are young adults going off to college or a mission or other adventure, look into the jurisdiction where you're going to be going to college, because you probably want an advance directive executed under that state statute. The other thing I would offer to people as a tip is, when you sign an advance directive, send a copy to your physician so they can put it in your chart. If you check into a hospital, they'll always ask you if you have an advance directive, and if you don't, oftentimes what they'll do is offer you a blank form from the UMA, Utah Medical Association, to complete. That's, again, not the time to be completing it. So if you can have one in your physician's chart so that they have a copy of that. There are also online cloud-based medical directive storage facilities where they will issue an ID card, and you place that in your wallet, and then a physician's or a hospital can log on and pull that right off the internet. So everyone needs one. Get it done now. If it's been a while, review it regularly. And I like the comment about it being emergency preparedness, not end of life.
And I think, Rob, we've also listed many websites that have how do you start the conversation, how do you choose a healthcare proxy. The website resources at the end of this presentation are wonderful.
I appreciate you referencing that. We'll make sure they're available wherever this is posted as part of the taping. Thank you. Thanks again to our experts, Attorney Troy Wilson, Dr. Cammie Collette, and thank you to our producers, Co-Imagine Health Utah and Glamati Road Pictures. And thank you for your time. Other topics of interest to older adults can be found at the Utah Commission on Aging website or YouTube channel. I'm Rob Entz, Executive Director of the Utah Commission on Aging, and this has been The Wrap on Aging.